Now I will briefly introduce today's moderator, who will in turn introduce the rest of the panel. So moderating today, we have Nicholas Livingston, who is a research psychologist in the National Center for PTSD Behavioral Science Division and assistant professor of psychiatry at Boston University School of Medicine. His areas of clinical and research expertise include minority stress and LGBTQ+ health, trauma, and PTSD and substance use. Dr. Livingston is a co-chair of the Sexual Orientation and Gender Diversity SIG, and we're so glad that you're all here today. Thank you. I'll turn it over to Nick now.
Thank you very much, Holly, for the introduction and for helping us organize this event. And thank you, everybody else, for joining. I've been very much looking forward to this. So what I'm going to do is actually just lay the groundwork real quick to set the stage for what we're going to be talking about today, and hopefully impressing why this topic is important. And then I'll introduce our panelists one by one in alphabetical order, and then we'll get into it. So for today, we're going to be talking about transgender and gender diverse individuals. And, you know, this topic is important for a lot of reasons, but the scope today, TGD individuals experience high rates of trauma, discrimination, and minority stress, including shame and expectations of rejection. You know, these experiences and stressors are important in their own right, but they're also associated with a myriad of psychiatric symptoms and disorders, including depression and anxiety, PTSD and substance use disorder, and also drive higher rates of attempted and completed suicide among TGD individuals. But despite higher risk of trauma exposure among TGD individuals, this community is significantly underrepresented in trauma and PTSD research. For example, in our recent review of clinical trial literature, we found that TGD individuals are still not visible in the trial literature, with 0 out of 390 published trials reporting on expansive gender identities in their studies. And this is notable for a few reasons, perhaps most obviously because representation is important. But in addition to that, the common co-occurrence of trauma and minority stress can complicate evidence-based assessment and treatment, and new approaches to treatment or modifications to existing approaches may be needed to meet the needs of TGD individuals. Fortunately, a growing body of work now focuses on the overlapping psychiatric symptoms following trauma exposure and minority stress, and how these experiences can be addressed in treatment and beyond. So this is a topic that I'm very enthusiastic about, but I'm not going to be doing most of the talking today, because here to speak with us and offer their demonstrated clinical and research expertise on the topic are 4 outstanding expert panelists. So I'll introduce each of them briefly by name, pronouns, and titles, then have them share a little bit about their own interests and background on this topic. So in alphabetical order, we first have Dr. Danielle Burke, or Danielle, she, her pronouns, who is a clinical psychologist and assistant professor of psychology at Hunter College and the Graduate Center of the City University of New York. Danielle, would you mind sharing with us a little bit of information about your background and interests?
Not at all. I'm really excited to be here today and honored to be invited to speak on this really important topic. As Nick mentioned, I'm an assistant professor at Hunter College. There I direct the Gender-Based Violence Research Laboratory. Our NIH-funded program of research explores pathways to healing and recovery among those who have been victimized by traumatic forms of violence. We focus on the experiences of sexual and gender minority people broadly, and the experiences of women under that umbrella more specifically. We're doing some longitudinal work, studying pathways to healing in a large sample of recently trauma-exposed trans folks in New York City. And we have a clinical intervention, implementation, and pilot trial on self-defense training as trauma prevention and trauma recovery. So I look forward to bringing what I'm learning about the challenges and the benefits of this kind of work to the conversation, And in my clinical work, I supervise graduate students at the City University of New York's graduate program in health psychology and clinical science. And I have a private practice where I specialize in the treatment of post-traumatic stress disorder among women. So I hope to bring those clinical experiences to the conversation as well.
I look forward to that. You know, in some of the questions that I have, I think that you'll be well positioned to speak to some of those, and I look forward to it. Thank you very much, Danielle. And then next we have Dr. Gus Klein, or Gus, he, him pronouns, who is a research scientist not too far from Danielle at the Hunter Alliance for Research and Translation, and he oversees their transgender health research initiative. Gus, would you like to share a little bit more about yourself?
Sure, hello, and I'm excited to be on this panel for a lot of different reasons. My training and background is in social work. I've been a social worker for now about 25 years. So most of my research is informed by both my practice and also really done with communities and specifically community-based organizations. And a lot of what I focus on is how do we actually develop more provider interventions, and how do we kind of intervene specifically in kind of stigmatizing and discriminatory experiences that people have when they go to get care, whether that's healthcare, whether it's psychological care, whether that's a social support services like shelters. And I think a lot of what my research is kind of moving into is this idea that over time, these experiences really do reflect traumatic experiences, that if constantly you're going to places that really are supposed to, in and of themselves, be safe spaces for you to get care, yet you're consistently, and this isn't, and I'm not specifically meaning just active discrimination where you're turned away, experiences of microaggressions or racism, that is, you know, all the different kind of experiences that people have. So that is the work that I do and right now, and we're kind of hopeful. Dr. Burke is a co-I on a study that we have here that we're hoping will be funded, which is a researcher intervention looking at trauma-informed measures in HIV stigma research with trans individuals. So, you know, we're really trying to kind of start a conversation to really make sure we're measuring what we are intending to measure in order to develop interventions that are really testing and helping people to actually thrive. So thank you.
That sounds great. And I look forward to hearing more about that as well. And I appreciate you bringing some social work perspective here, because really this topic spans multiple levels, micro through macro, and it's easy to get singularly focused on one of those things, but I think the risk of that is low with this panel today. And I also like that you brought up started to bring up this distinction between, you know, minority stressors and trauma. I think we'll get into that as well. Great. And so next we have Roman Ronzone. I hope I pronounced that correctly, and I'm so sorry if I didn't. He, him pronouns, is a PhD candidate at the Autonomous University of Madrid in the Department of Clinical and Health Psychology. Roman, would you mind sharing a little bit more about yourself?
Well, thank you, Nick, and you pronounced it well. Thank you. Well, thank you for having me and for the hard work behind the organization of this panel, which I think is really important, not only because of the topic itself, but a way of honoring Transgender Visibility Day, which was just last week. I do think that these kind of meetings are essential for the outreach, increasing visibility and awareness and acceptance nowadays. Well, my research encompasses the identification of adverse interpersonal processes, such as childhood maltreatment, IPV, and trauma in Latino and LGBTQ populations. But right now, I'm focusing on research of IPV trauma among LGBTQ plus individuals from Spain, along with an amazing team with different identities and cultural backgrounds. We have people from South Asia, Europe, Latin America, cis and trans people, which, by the way, I totally recommend when doing research with minorities, since it allows a deeper understanding of the problematics and realities experienced by diverse samples. We're working on a mixed method design because what we have found is that current measures and tools do not cover the spectrum of life experiences of sexual and gender diverse identities, especially those with multiple intersecting marginalizing identities. So by doing these interviews and gathering qualitative data, we are trying to make more sensitive tools and informing research tools in order to get more adequate data and to somehow get a better understanding on how minority stress and trauma is lived by Latino samples in Spain.
Terrific, thank you so much. You know, and I appreciate that you bring up the intersecting identities piece. I'd like to get into that as well, similar to the way that Gus brought up the intersections of experience, whether it be conceptualized as trauma as separate from minority stress, whether they're seen as intersecting or, you know, part of some spectra. So I think we're going to get into a few different intersections here, and I appreciate that perspective in advance. And then last in the alphabetical lineup, we have Dr. Colleen Sloan. She, her pronouns, who is a clinical psychologist at the VA Boston Healthcare System and assistant professor of psychiatry at Boston University School of Medicine. Colleen, on to you.
Thanks for the introduction, Nick. And thanks everyone for having us. I'm Colleen Sloan. I'm a clinical psychologist at VA Boston. My clinical post is within the Women's Trauma Recovery Team. It's an outpatient trauma specialty mental health clinic that serves a diverse community of women veterans ranging across diverse demographics, but a good bit of gender diversity and sexual orientation diversity as well. I provide direct clinical training, service, supervision in that role. For about 8 years at VA Boston, I chaired our interdisciplinary transgender treatment team. And in that role, I worked really hard to expand representation across disciplines and to enhance the care that we were providing our gender diverse veterans. For the past 5 years, I've also served in the role of LGBTQ veteran care coordinator, which has been a wonderful way of connecting with sexual and gender minority veterans and ensuring that they are getting the care that they need and addressing any issues that may arise in any of their VA care. This also is a role that has afforded me the wonderful opportunity to serve as an educator and trainer for VA Boston staff employees in the areas of sexual and gender minority health. My research interests are oriented around modification of evidence-based psychotherapies when working with marginalized populations, with a particular focus on sexual and gender minority populations. Some of my areas of expertise are around utilization of prolonged exposure and dialectical behavior therapy. I've worked with others to develop a DBT skills training group for transgender and gender diverse veterans, and we're currently collecting data within that group just to better understand how this group is functioning for an underserved, historically underserved community of veterans, to better understand what this kind of looks like for this marginalized community, and hoping to expand upon that. Thanks for having me.
Thank you so much for participating today, and also for all of the great work that you just outlined. Colleen and I are, well, you know, when we're both working on site, are just floors apart. So I get to witness all of the benefits and great services that Colleen provides, and it really does have high impact. So thank you so much, Colleen, for being here and for the work that you do. All right, so, and Holly already introduced me. But I'll just say quickly, Nick Livingston, he, him pronouns, the rest has been stated. So for today, and I know that time is short, so we'll just get into it. There are a few things that I thought we might touch on today that I suspect folks will have interest in. And while I have some questions of my own that I'd like to ask, I'm sure the audience members have some as well. And so I and other co-chairs who are attending will monitor the chat during the discussion and try to pick out a few questions that might come up that complement our discussions, our discussion. And for those questions that perhaps don't, or questions that come later, we'll leave time at the end for folks to ask questions if they have them. And our topic today is certainly bigger than that which we can fill in an hour, so we'll go ahead and get started. I have a series of questions, and I'll invite each panelist to respond to each of those questions, either in a first come, first serve fashion, or we could do it, alphabetically in the order in which you were introduced. We'll see what makes sense as things progress. It seems like a pretty polite and respectful crew, so I don't know that I don't think I'll need to moderate too much. So my first question then, given each of your demonstrated expertise in trauma and minority stress among transgender and gender diverse individuals, I'm curious about your thoughts on some of the ways that trauma and minority stress present in the transgender and gender diverse community. And some of you already alluded to some of this in your introductions, but I'm curious about your thoughts as we spotlight this specifically.
Well, I can speak to that question because I both come first alphabetically and in perhaps level of eagerness. I think it's a really important question, and I think first to answer it requires a lot of clarification of what we mean by the question. So the question, like, how does trauma and minority stress present? I think we can ask it in terms of highly stressful, health adverse experiences that overlap sometimes and are distinct sometimes. So in terms of their presentation, I think we can ask, how do these experiences present in the world and then are perpetrated against trans and gender diverse people? And then we can ask the question, how does the impact of those experiences present in the blocking of thriving and functioning of trans and gender diverse people? And each of those questions, I think, requires an entire program of research and clinical intervention and community engaged activities focused on both of those problems. What is the nature of the harm and what is its impact? In terms of my perspective on the nature of the harm, in my research experience, I've done a lot of work recently administering our very tried and true evidence-based assessment tools, the CAPS, clinician administered PTSD, structured interview, to try to hear more from trans and gender diverse people about the extent to which the experience of haunting, ongoing, impactful, stressful experiences, whether we label them criterion A within the DSM or not, but whether or not the ongoing impact of the most haunting things that have happened to someone in terms of environmental, externally imposed stress, whether or not they fit within our structured assessment. And invariably, I find that they both do and they don't, which is maybe not a helpful way to answer the question, but I'll say a little bit more about what I'm seeing. I think the number of ways that people are haunted by externally imposed high impact interpersonal stressors is as variable as the number of people who are impacted. And as clinical scientists, we think about the application of ideographic, functionally analytic, contextual conceptualizations of the etiology of distress in our clients. And I think so too, we need to be thinking as ideographically about what has happened to you and what does it mean to you before we can start answering questions about how that impact and its meaning are impacting clinical presentation. So this is my broad response about the framing of the question. And I think like my research and clinical bias to asking about the answers I'll let others join in, as I'm sure I'm not the only one who has thoughts on this.
Thanks so much, Danielle. I know I'm working a little bit out of alphabetical order. Danielle, I so appreciate you providing this kind of broad framework that really helps us understand the kinds of things that we might be seeing in research settings and in clinical settings. So I first want to just speak from my perspective as someone who served on Veterans Health Administration's National Expert Training and Consultation Team called Transgender Scan Echo. So this was a team that essentially functioned to provide trainings to VA teams nationally in the care that they were providing to transgender and gender diverse veterans. And then we also provided consultation on particular cases, so live cases that representing veterans with whom these teams were working. And this is really what piqued kind of my interest in better understanding ways to conceptualize clinical distress we might see in trans and gender diverse people. So one of the most common kind of consultation questions I received was around clinical presentations indicative of pretty significant emotional and behavioral dysregulation patterns. So kind of complex mental health presentations that, kind of looked like trauma, also had co-occurring substance use. There might be disordered eating, certainly things like depression, anxiety, et cetera. And then, really chronic issues around just kind of stability in living. So problems with housing, employment issues, et cetera. So it really gave me, unique and direct insight into the chronic areas where transgender diverse veterans were really struggling and how difficult it was to even address those things, to even get them in the room to provide evidence-based psychotherapies that we're not really sure haven't been normed on transgender and gender diverse people. And there were lots of questions around personality disorders, which I think is problematic to kind of pigeonhole some of the things we might see transdiagnostically as indicative of personality problems, when in fact these emotional and behavioral dysregulation patterns that we're seeing from folks who are chronically invalidated and marginalized are actually completely reasonable responses to systemic stigma that's pervasive throughout the lives of trans and gender diverse people. So I think, I imagine that we're going to talk about this in just a moment, but the dialectical framework, the biosocial model that describes how emotion dysregulation, behavioral dysregulation develops, I think is a very useful framework to understand why we might see these clinical presentations for communities of people who are chronically invalidated and marginalized. And so I think that we have useful models. We just need to be more thoughtful about them and integrate the models that we have that are evidence-based with our minority stress models as a way to enhance our case formulation, to enhance the assessments that we're using in clinical practice, and then thinking and being thoughtful about the interventions that we're employing as well.
I just want to interrupt and say that I really appreciate you speaking to the adaptations to minority stressors and high impact experiences that you've come across. And I think that, I agree with you. And in my experience, people do have a tendency to pathologize the reactions without acknowledging the extreme nature that is called and still requires those sorts of reactions, which might seem maladaptive and totally maladjusted, or maybe even characterologically flawed, for lack of a better frame. But people often overlook the perhaps adaptive function of those, ongoing adaptive function of some of those responses. And so I'm glad you brought that up, and I'm looking forward to getting into that in more detail as well. And, with respect to this question, Roman or Gus, do you have any thoughts yourselves that you'd like to contribute?
Well, from my experience, I will also like to speak from my experience. I've been doing research in 3 countries so far. And what I found, despite the cultural differences and legislations, is the high prevalence and consequences of adverse interpersonal processes, like marginalization and invalidation, as Colleen said. It's not something related to a specific country or a specific culture. It's an experience that is still notorious all over the world. And it's corroborating that across the 3 countries, not living an authentic life can have like a lot of detrimental effects on the physical, emotional, and mental health of the people. According to our data, the recent data that we just gathered in Spain, exposure to marginalization and stigmatization places TGD individuals in a greater risk of exposure to mental health problems, as Colleen stated and Daniel stated before. So we are not only speaking about differences in between LGBTQ plus individuals and non-LGBTQ plus individuals, but also differences inside of the community. Because also inside of the community, there are some kind of microaggressions that are present nowadays against TGD individuals that we must also recognize in the investigations, and we should also like take into consideration when we are working with TGD individuals. I would like to point that.
Thank you so much. And how about you, Gus?
I think that there are, just had a thought, and I hate when this happens, it leaves my mind. You know, in thinking about some of the work that I have done, specifically around like qualitatively with both trans feminine communities and trans masculine communities, about kind of health care interactions, whether that be with therapists, whether that be with a medical provider, that I think one of the things that is, you know, I think going back to Danielle's like question of like, what does that mean to you? I think a lot of times what I'm finding is that there is an internalization that happens, that whereas if something happens or a discrimination happens or something worse happens, that somehow as a trans person, it's very always weird for me to be like, the trans person, what someone in one of my studies would talk about is that it was my fault. If someone misgenders me, I didn't either change my presentation in a way, or I didn't correct them, or if something happens. And I think that, you know, that also to me speaks along in terms of like, what are people's like adaptive processes, right? Like, how do we prepare ourselves to go into these situations? And also, if you are constantly in a hyper aroused state, prepared to be discriminated against, and you go in for an assessment, you are not like, I would, you know, like we have to think about all of that. And how do we also, a lot of it's like, how do you even create an environment that where you can have somebody to shed those multiple layers that they need to, or armor, I guess is the only word that I can think of right now, that they kind of come with. And I think that, you know, what everyone is talking about is just kind of this insidious nature, and what we may often see as classic or kind of symptom, like, you know, PTSD symptoms, or what is people call as maladaptive, are really these coping strategies that if I was homeless and doing sex work and, you know, had very little social support, I would absolutely be on drugs because it would help me to survive. And so I think that and what happens is, I think when we ask people, and this is so much of what I do in trying to figure out how do we measure these constructs, and how do we ask people these questions, specifically, how do we do that in research in an applicable way to practice? Like I really believe in there should not be a separation. Is that like, how do we help people to identify it? Because a lot of folks cannot articulate these experiences, and I think it's because they're actively experiencing them all the time, so that like you have to validate, like I have, and I say this from as a person who have asked these questions to hundreds of trans people now, and had multiple people say, wow, that was the most affirming experience I've had because I validated their experience. And so if they're not only having this validation in research, that's a problem. And I think we, you know, thinking about, you know, the ways in which we really kind of not just like diagnostically approach this, but like on a human level, like humanistically, how do we kind of like really engage people?
You know, and I think that's a really good point, and it's also a really timely segue, because another question that I have that dovetails from this discussion, and also too, I see a question in the chat: what is something that I can do in my clinical practice starting today that will help me better serve my transgender clients with histories of trauma? Well, and I'll pause just to kind of sidebar here real quick. Some people might be trained in providing evidence-based trauma-focused assessment and intervention that may not be inclusive of minority stress or other, compounding stressors that are true for TGD individuals. So with that being said, in your experiences, what impact does minority stress, especially ongoing minority stress, have on trauma-focused treatment? And to Christopher's question here, what are some practical applicable skills that you all might suggest to help people who are doing this work today? It's a big question. I'm sorry. I'm happy to reframe it, but if folks have any thoughts on that, go ahead.
I think the attendees of this panel, the members of ISTSS, and those who watch this recording are very well positioned to do tremendous good in the lives of their trans and gender diverse clients who are surviving trauma and chronic marginalization. And I think to extend on Gus's point, trauma therapists and interventionists and researchers who are trained with expertise in trauma know how important it is to have a space to name the harm and to differentiate the source of the harm versus its impact. That is what I think, despite all of the variability and hypothesized mechanisms of action and preferences for delivery across our evidence-based treatments are across that variability, I think that is something that unites all of us in our trauma work, is that these are things that have been historically part of systems of oppression, right? Interpersonal trauma in particular are ways that we control one another and maintain power systems that benefit some and harm others. As trauma therapists, as trauma experts, our entire field is dedicated to saying these processes are not natural nor inevitable. They're externally imposed, and they have impacts on our mind, body, spirit, psychology. And I think extending that to say minority stress, gender minority stress is included, and let's name it. So when I ask you, what happened to you? What's your life been like? In what spaces have you felt affirmed versus in what spaces have you felt like you've had to walk on eggshells, be invisible, that your survival is constantly in threat? What are the causes of those feelings as you understand them? What is the role of who you are as a person, your gender, your race, your family history, where you live, the social support you have around you? What is the influence of those kinds of factors on how you've been coping with these things that happen to you? These are all questions that I know that any one of the myriad thoughtful trauma psychologists, social workers, clinicians in this space ask all the time. So I think we're all really well prepared to start doing this work right now for our clients. It's just a matter of not being afraid to name gender minority stress can be traumatic and often is. And let's talk about it, its impact on you. So that, as Gus said, we can name the water that feels like just the natural environment we're breathing in and swimming in.
What a potent suggestion too. I think that cutting through the alienation by touching on it specifically, helping to name it explicitly. By the way, like, it is a hard thing for some people to name. If there's something that you've grown so accustomed to, it can be a little bit hard to report on. I think about multiply trauma exposed folks that I work with and trying to pick one index event to anchor an assessment to, and they look at me like, are you kidding me? Like, what? I got to pick one. And it's hard. And when you compound that with minority stress, which for some could be daily, or multiple times daily, to get people to speak to the impacts of something that seems so habitual can be really challenging, and putting a name to that and validating that can be so huge. But having these conversations, a way of cutting through that alienation, and even better, I think, normalizing their reactions, because only thing worse than alienation in this respect is feeling like the thoughts that you have and reactions you're having are in some way not in alignment with reality. And then oftentimes they are. And like, what a tremendously powerful thing to be able to do just that. So I know that's kind of an abstract idea in one sense, but in another real sense, that is a tangible thing that anybody could do today.
Yeah, and,
so
I'm sorry, I'm just so excited. I'd just like to add to that point about also who has the expertise and authority to do the validating. I think it means a lot more. I mean, it's important that people who are given the title and role and have the opportunity to be trained so that they are called experts do this validating, but having this community engagement, community care, peer support, context for this kind of naming and bearing witness to and validating and supporting is really important. I saw a wonderful talk that Judith Herman gave at an ISTSS panel a number of years ago. And she said something that has stuck with me since, and I think really applies well here, is that she talks about, in her multiple stage model of trauma recovery, the importance of group work and group therapy early in that process, and how she would find how often members of a community in that group, after another person in the group would share what had happened to them, oftentimes with flat affect or emotional distance, or a quick move to say, but it's okay, I'm strong, I'm tough, I'm coping. How much easier it was for the other members of the group to share their righteous indignation and sadness and pain. That there's a level of validation that sometimes we're able to have for those close to us that we struggle to experience for ourselves when we're so focused on survival. So yes, I think that clinicians and providers can do this, but I think it's especially valuable to support the creation of clinical community spaces where this is just part of what happens.
100%. Thank you. I appreciate that comment.
Just to piggyback on what Danielle's mentioning, what you're largely speaking to is just the importance of a patient-centered approach and any kind of clinical work that we're offering. And I appreciate the value of having expertise and professionals within the field, and integrating that with the expertise of the individuals and their own lived experiences. As folks who might consider themselves expert in the field of trauma, I think one kind of pit that we can fall into is naming traumatic stress as worse than minority stress. And that is obviously a mistake. And if you've ever worked with somebody who's marginalized, you have probably heard that from their mouths, that they may be talking about everyday minority stressors. I mean, I appreciate Gus mentioning earlier the microaggressions. It's like death by 1,000 cuts. On a daily basis, those kinds of chronic experiences do matter, and the cumulative kind of subjective impact can be greater than one traumatic stressor. And of course, we know this from the literature and our clinical experiences that many of our trans and neurodiverse folks are coming in with both having experienced traumatic stressors and minority stressors. And so I think that we need to really let our clients kind of guide the discussion as well, and validate whatever they're saying is most impactful to them. And then in terms of our interventions that we're using, it's going to be complicated. Recovery from trauma is obviously complicated by things like minority stressors. And so we have to adapt what we're using, because of course it would be unreasonable and frankly invalidating to ask one of our marginalized clients to evaluate the evidence for and against a maladaptive thought that actually might be very adaptive for that person existing as a marginalized person in a larger environment with chronic stigma. Or if we're using behavioral interventions or exposure therapy, I need to know what my environment looks like when I am assigning in vivo tasks, because that would be different for a Black trans woman compared to a white cisgender heterosexual man. And I need to know these things. I need to know about demographics and the degree to which they hold or do not hold privilege. And I need to know my environments outside of even my therapy room. So I think the concept of activism and advocacy kind of takes a different, meaning when we are working with people who are marginalized. It's and not to say that this is not true for anything, but it's not everyday psychotherapy. It's not just in the room, it's outside of the room as well. And I think as mental health professionals, we're in a unique position to do kind of broader impact type of work in that way.
Well, I want to pluck a few insights here, because the one actionable, tangible thing that it sounds like you're recommending, and I certainly would agree, but just to highlight advocacy being a big piece. How do you provide treatment to TGD individuals? Well, what I didn't hear you say is we need to throw everything out and start over. What you're talking about is adaptations to things that we know to be efficacious already, mindful, sensitive and appropriate patient-centered adaptations. So part of that, I think, is like having a proper and effective case conceptualization that is truly patient-centered. So we're going in with questions that we should be asking, I think, and being thoughtful about that, but not going in with heavy assumptions one way or the other, but really learning from the person what's true, what's high impact, what hurts, and jointly coming up with a plan for how to approach that, as a way of taking the best of what we've already been trained to do, matching that with the needs of the patient in the moment, and then proceeding from there.
I think what's interesting, someone also put in the chat, like kind of what kind of systematically or structurally we can also do. And I think that Colleen, and I think what everyone is talking about too, and what comes to my mind is that like trans and gender diverse folks don't have access to this type of therapy. So like first and foremost, at a structural systematic level, like we need to figure out, one of the reasons I was like, oh, absolutely, I would participate in this is because there is a disconnect between kind of the expertise that all of you have in terms of doing this very trauma-informed, patient-centered, thoughtful work and what we call gender therapists. And so like at the baseline too, I think is that like the process of whether it's like going through transition or having to tell your story and having to justify that you are gender dysphoric is a traumatic experience, and also what that does to a person and how that also disconnects them from probably all of the other stuff they have. But first and foremost, the most time that someone will actually be able to get into therapy is just to access treatment, and all they're doing is telling the same story over and over again. So, my hope would be is to how can we like synergistically work together to be able to like train people who desperately need the training in trauma-informed work, and how to teach them to do these interventions or adapt them, because there isn't any, as everyone has said on the panel, and as all of you know, there isn't an either or, there is an overlap of all of this. And so, I think we want to, it's easier to focus on the individual because we have these tools, and it's so frustrating to do the system because it's really messy. But in order to increase access, a lot of, the work that I do is with community-based health centers, so FQHCs across the country. And, mental health is their number one issue right now, both in research and both in access to services that they have very little capacity for. And they have extensive waiting lists. They have no ability to vet any of the providers that if they have a relationship with someone, they say, I know that you can see this person because you will X, Y, and Z. But outside of that, they don't really have the capacity. So, but because they are these LGBTQ plus health centers, that's where people are going, because they, at least at a baseline, feel that they are going to be treated with respect. And so, but there are also not any sort of, we're kind of starting to talk with them about what are potential interventions you can develop that are stopgap, because if waiting lists are 6 months, a year, Never. What can you, trauma and experiences and crisis don't go away, as we know. And so I think that, and maybe this is the community-based social worker in me, is that like and speaks to the advocacy part, where it's like we can collaboratively do this together. And I appreciate this conversation because it's really moving this work past pronouns and this basic. This is about actually like, how do we do the work together to really, as Danielle says, like help people thrive and heal.
Yes, I would like to retake this point stated by Gus. I do totally agree about the situation of non-security of TGD individuals feeling in the social security system, also in the academia. And I would like to state, for example, the interviews we're doing right now to take qualitative data regarding the experiences of trauma and also the experiences related to the social services. We have found that TGD individuals feel unsafe. Hospitals feel unsafe when they go to the psychologist. It's exactly because they just go there when they have to be examined, to be validated as the persons who we are, who they are. And that's a main problem right now. And it's also difficultating the research situations. For instance, when we have tried to gather data to get our sample, sometimes people feel like suspicious regarding the questions. They don't want to answer. And we have to make like an special effort to get to the sample. What we have found to be useful, if someone would like to try it, it's to get in contact with influencers. It sounds crazy, but getting in contact with influencers on Instagram and Facebook, people feel a little bit safer because the information is coming from someone who understands, who have felt the same situations, who have been traumatized in the same way. And at least that person is allowing them to get into contact with psychology. So we have found very interested people in the topic. Even they want to get in contact with us to continue with the research once they find that there's a valuable source to get in contact with, not like the traditional psychologists they will find in the social security system. So we have a lot to do there. We have to make conscious, to make awareness, to get somehow in contact with the people that are actually needing these interventions. That would be.
Yeah, I I appreciate that, and what you were saying, and then also what Gus was saying, was also complementing to this question that was put in the Q&A about the importance of advocacy, and how important is that for empowering TGD clients. And one thing that you were talking about, Gus, is the unmet treatment need among TGD individuals, and that's assuming too that everybody who could benefit from care is trying to get it, but there are a great number of folks who could benefit from care who won't seek it. There are practical barriers too that plague us all, like it's inconvenient to carve out time and take time off work and to drive to a location. But the other piece too is that a lot of TGD individuals have reported some pretty negative experiences in healthcare. And why not have some basic mistrust of a provider and healthcare system that over-pathologizes TGD identities, or that has a fundamental misunderstanding of the healthcare needs of TGD individuals. So these are some of the barriers we're up against, and also in extreme cases of people experiencing discrimination, microaggressions, and even cases of assault in healthcare settings perpetrated by providers, even in some published cases. So I would say, to the point of advocacy, I think yes, maybe even as a bare minimum, and outreach as well, because providing corrective experiences and letting people know what resources available is important, and also knowing that might be met with extreme reluctance, which again might not be a distortion. It might be an adaptation to previously negative experiences in healthcare. And I was afraid this was going to happen, that we would run out of time because there's so much to say. I'm sorry, I'm going to blank my screen here because my computer timed out. I do have another question that I wanted to get to to start to round things or start to bring things to a close on a more positive note, and then with any remaining time, perhaps address any additional or remaining questions from the audience. But I wanted to ask everybody on here, and for the sake of time, I guess we can think of, of briefer responses, but this is kind of a two-part question. So if there's a part of it that connects with you, you can answer that, or you could answer both. But what are some of the positive trends you're seeing in this space, either clinically or research or outreach related? Or what directions do you suggest for the field moving forward that would be timely and important for promoting TGD health? So positive trends you're seeing, or things that aren't happening that should?
I'll do my best to speak about this briefly because I think we could go on for a while. But I work within the VA, and this is a healthcare system that is incredibly large and definitely has its own history, and I think has made great strides in terms of the care that is providing for trans and gender diverse veterans. Structurally, I think what is incredibly important about the success of these kinds of initiatives is utilizing both a top-down and a bottom-up approach to addressing disparities and inequities in healthcare. So for example, there is a national program within VA Central Office, the LGBTQ+ program, that is responsible for memos and directives on the provision of care for sexual and gender minority veterans, and at the same time, also designates kind of a boots on ground approach. And so has folks, I mentioned my veteran care coordinator role earlier, but it's not just about having directives. Those things are absolutely necessary because we do need policy to rely on to ensure that we can say, no, this is not how we're doing things. We're doing it this way. That is indicative of affirming care. But then we need the folks within the actual facilities doing that work and ensuring that those things are happening, providing the trainings, listening to stories and narratives from veterans around, how they're actually experiencing this. Certainly for large healthcare systems, I think it's easy to be like, oh, well, of course we're not misgendering anybody because the directive says we shouldn't. And that happens, right? And so we need to be knowing what the physical space actually looks like. What are the actual experiences? Where is my veteran being misgendered? Where can I target my education and training efforts to ensure that those things are not happening, to remove those barriers? And, every facility is different. So I think, at a good guideline, I think, is to think top down and bottom up when you're trying to address inequities for any marginalized group, but in particular, trans and gender diverse folks.
Thank you very much, Colleen. How about others? Positive trends you're seeing, or something that you would like to see happen?
I can speak to some of the positive trends specifically. I know that it's a concept, but I think it's also been used a lot more now with COVID in terms of talking about mutual aid. And then I know in New York City and Chicago, and obviously these are large cities, and they do not address any other issues in terms of like rural or access issues. But there has been a movement among Black and Brown trans folks, specifically Black and Brown trans women, around mental health. There's like I'll send resources where people are actively trying to get therapists of color to kind of coordinate and provide services to folks, whether it's for low cost or free. Some of these organizations, and they really are from the bottom up. I mean, these are people who are saying we have a need, and for X, Y, and Z, I had access to these services, and so I know how important they are, and I want to be able to help my community to get access to these services. And I think the more that we reframe and rephrase the way that we think about minority stress and think about these to really talk about trauma and to talk about kind of healing and thriving and resiliency, and kind of also, the sad part in terms of research is that we actually we maybe put in a resiliency measure here and there, but we actually do. And yes, we know advocacy and community support and going out and protesting, all people feel really like, I feel a part of it. It's like, because you're a part of a group and who have a shared identity. So, but I think that we really need to actually spend more time actually investigating what people are doing and like what that really, the ways in which what we call adaptive, you know, how are they actually, how are some of these positive and how do they work? And also how are people who with limited resources, who have all of, who have so much intersecting structural oppression and stigma happening, how are they thriving? Because they are. And I think that we have to also understand, I think that, you know, if we can move toward also these kind of both research and practice, moving toward identifying what people are doing that's successful, as opposed to continually telling us how horrible our lives are, I think that it would go a long way. And I think that I know that it would absolutely mean a lot to the community that I am a part of, and also the community that I do research with, because people are tired, and they're tired of really kind of being asked over and again and being told how miserable their life is. And I volunteer my time with parents of trans kids, and they would really appreciate that too, because they are terrified. And obviously we see in Texas and Idaho, and there are real reasons, but I think that if we could actually show them what is actually happening, that would be super, super helpful.
Yeah, especially despite all of the adversities that we can, what I acknowledge right now is the recognition of the resilience and the good things that we have as a community. Maybe the social support that could help us regarding the bad experiences that has shown to be really important when it comes to confronting minority stress and trauma, to acknowledge those situations that are like the best part right now. Also, I would like to thank articles like the one that Nick just published this week regarding recognizing pronouns and names in whenever you're doing research, no matter if it's research focused on LGBTQ community. I mean, it's important to name it, to recognize the existence of the community, in order also to point out circumstances that are happening and are good, or maybe they are not that good, but just to recognize it and name it is important.
Thank you so much. And, you know, it pains me to announce that we are at the end of our time. I could talk about this forever, but we can't, though hopefully there's additional support for programming like this in the future. I know I'm open to it. And I know too that we got to a few attendees' questions, but not all of them. And I'm looking at a few really, really great ones. I did put my email in the chat, nicholas.livingston@va.gov. I would welcome follow-up. And if panelists are open to that as well, I'm happy to forward your contact information along. So I just want to close by sincerely thanking our panelists for their time today. I'm very grateful to be among the benefactors of all of your hard-earned insight into this extremely important topic at a time when it's more important than ever before. And I also want to thank ISTSS for their support in hosting this event, and especially in honor of Transgender Day of Visibility. It is through programming like this that we're able to spotlight these important issues. And then lastly, thank you for all of those of you who attended. We had quite the audience, and I'm grateful for that as well. Thank you, everybody. Take good care.